All right. Welcome to Osmosis's weekly Ask Me Anything. This is something we've been doing for a few weeks now. My name is Dr. Rishi Desai. I'm the Chief Medical Officer at Osmosis. Love answering these questions, and that's why we keep doing it, to make sure everyone's up to date with the best information out there. I want to remind you of the importance of staying at home, and also that we are trying to run a whole campaign around flattening the curve, but also raising the line of healthcare, meaning more supplies and more people to the front lines. If you want to learn more about that, go to osmosis.org/COVID-19 and learn what we're doing right now, so that you can kind of join our effort there. We're in fact giving away 3 weeks of Osmosis Prime if you sign the pledge. So please go ahead and do that if you haven't already. We're going to dive into a couple of topics here. So one is a question that comes up a lot. How long is this pandemic going to last? And if you look at the modeling that's been done around this, if we continue to isolate the way we're doing in the US, and this is actually something you can look at for each country around the world, it looks like this week is really the peak week for many states in the US. Now, I say many and not all because there are some states that actually peaked before this. Washington, for example, actually already peaked. There are some states that are going to peak well after this. A quick example there would be Florida. So, it really depends on when this starts to rise in your state as to when the peak is going to happen. Around now is when many states are peaking, and in terms of when is it going to last, it's going to be a downward slope for the country if we continue. And that last little bit, we can probably take care of with a stronger public health system and more testing. Speaking of testing, one big part of testing is serology testing, looking for antibodies. And people often wonder, how long does immunity last? The first things first, it is clear based on the numbers that probably the very small minority of people are going to be immune. Because if you just look at the numbers, the majority of the US was not infected probably by COVID-19. I say probably because a lot of this is based on sampling of how many people we've actually tested to figure out how many people are out there that may be cases that never got picked up. But it looks like roughly 1% of roughly 1% of Americans are going to show immunity. And that immunity, based on other coronaviruses, typically lasts for a few years. So if that's the case and is true for COVID-19, that means that we have folks in our society that are now relatively immune to getting reinfected. The reason that we're seeing some cases where they have COVID-19, they go home, come back with COVID-19 again, may be best chalked up to false positives or false negatives, or that those individuals have some sort of immune deficiency. So that's probably a situation that has more to do with the testing than the fact that they're actually losing immunity in a few weeks and getting disease again, which is highly unlikely, and I don't believe that that's the case. In terms of how do they test for COVID-19, the two big tests, I mentioned serology already. That's the antibody test. Really addresses the question of did you have COVID-19 in the past? The other one that has been talked about the most is RT PCR, and that's really looking for virus RNA to see, do you have any evidence of the virus in your system right now? So those are the two different types of testing. Next question, what ways to thank healthcare professionals, how to handle being a healthcare professional, living with other people. In this day and age, a lot of our healthcare professionals are getting a lot of recognition that frankly is long overdue, because they put their lives at risk every day. And I don't mean just doctors and nurses, which are often the two groups that come to mind. I mean everybody: respiratory therapists, pharmacists, dentists, etc. So all these groups need recognition, all the way down to the folks that actually keep the bones of the hospital kind of intact, that keep everything running. So that has to do with the engineers that do the lighting in the hospital, the folks that help to keep the equipment maintained. So everybody that's involved in the hospital is really deserving of recognition right now. And a couple of concrete ways you can get involved are there things like adopt a healthcare worker programs, where you can literally go and do drop-offs for groceries and things like that they may need help with. So all that aside, let me just dive in and start answering some questions. Does temperature or season affect the spread of COVID-19? This is a question that's come up quite a bit. And in fact, there's a couple of answers here that are a little bit more nuanced. Let me get into the nuances here. One is that we know that the virus lives on surfaces, and we know it can survive on surfaces for hours to days. So with that knowledge, we also know that when it's more humid or more hot, the virus doesn't do as well. So maybe there is something to be said, and this is coronavirus rather than coronavirus as a class, rather than data specifically in SARS-CoV-2, which is the virus that causes COVID-19. But other coronaviruses typically don't do as well in warmer temperatures or more humid conditions. So maybe in those areas, we'll see some less survival on surfaces when it gets warmer, when it gets more humid. Having said that, we've seen plenty of cases in humid and hot countries. So really, it's hard to say how much that's really going to bear out for this virus. The other issue is there's data, and I'm actually going to be doing a daily video on this to get into the details of it, but around vitamin D. And we know that you get more vitamin D as the summer approaches, where there's more sunlight. And maybe there's something about vitamin D as a seasonal stimulus to our immune system, and that might actually help us contend with respiratory viruses like SARS-CoV-2. So there might be something about our body and biology, as well as something about how the virus deals with the summer and the humidity as well. So it really remains to be seen. I think the fact is most of this is a little bit to the side point of the fact that we just have so many cases, and most of the transmission just has to do with the sheer numbers and the fact that different countries are going to seed each other. So even when it's really gotten low in, let's say, the US, you might see a surge of cases in another country. And as visitors come in, you're going to see more and more outbreaks for those reasons, remembering that most people are still vulnerable and that really just the minority are immune. Next question. What do I think about chloroquine? Great question. There's chloroquine, there's hydroxychloroquine, there's azithromycin. A lot of these medications have been talked about quite a bit. The data on chloroquine specifically is, I would say at the moment, very, very tenuous. I've seen papers that show that it might be helpful, but there's been very little data, and it's been used in the context of people getting other antivirals. And I've also seen data that shows that these medications, specifically hydroxychloroquine, has not been very effective. And so at the moment, really what we're looking for is a randomized controlled trial. The best data I've seen has shown that it's been very equivocal in terms of whether it works or doesn't work. And that doesn't even get into the toxicity, where clearly there is much more toxicity in the groups that get hydroxychloroquine versus the groups that don't. So it's unclear whether the benefits outweigh the risks. And I think it just comes down to looking for more data on that. Next question. Thoughts on remdesivir and the body of evidence around that? This is a quick answer. I have reviewed some of the data, and it was actually a few weeks ago. And as you must know, remdesivir has been used on a compassionate care basis, so meaning very, very sick people can get access to remdesivir. But outside of that, the randomized control trial data is out. So we don't have a ton of data to go on. The case reports that were filed on the use of remdesivir were promising. Actually individuals that were sick, in many cases, let's say 10 days or more into their course of sickness and were not doing well at all. One patient in the US got remdesivir and improved. So that's one patient. It's unclear exactly what made that person better. So we'll have to see as we get more and more data on it, whether it's effective. All right. Can you explain ACE2 receptors in lungs and how it correlates in this situation? So there's a lot of concern around exactly what we're seeing with ventilated patients. And in fact, I just did a big study or look into kind of the two types of patients we're seeing. So there's more and more recognition that maybe the disease is not purely related to ARDS, but that there is a sepsis component of this, meaning that there's disease in the bloodstream as well as disease in the lungs. The reason that this relates to ACE2 receptors in the lungs is that the question is exactly what's the mechanism for disease in the bloodstream and what comes of that. So let me try to break this down. One study showed that there's L patients and H patients. So L like low, H like high. H patients are your more classic patients. These are people that come in, lots of disease in the lungs, you use a ventilator, and they presumably benefit from a very traditional ventilation strategy. The L patients, L being low, they're quite different. And in those patients, there doesn't seem to be a lot of pulmonary disease. There's not a lot of disease in the lungs. And in fact, those patients have more disease, we think, in the blood vessels. And it might be that it's related to the fact that SARS-CoV-2 binds to ACE receptors, and maybe that's somehow causing tiny little blood clots to form in the blood vessels. If that's true, and that's the real cause of their disease, then what we need to do is help better blood flow get to the lungs And the way to do that is by using something like low molecular weight heparin. And in fact, studies on low molecular weight heparin show that maybe in very severe patients, there is some benefit. So it's very, very early to say this, but I think that we'll have to do more study around the use of low molecular weight heparin to better understand what's happening in the lungs, and maybe some benefit might occur for some of those patients that are very sick, more from the L type, the sepsis, versus the H type, the ARDS. All right. Next question. What do I think about early ventilation versus waiting to intubate? Same question, essentially, is what I just said. I think most of the guidelines out there say try to wait to use a ventilator as much as possible. So if you can use, oxygen therapy in the nose, or high flow nasal cannula, or maybe even other strategies like CPAP or BiPAP, anything to avoid ventilation, because the fact is roughly half of the people in some studies that I've looked at, roughly half the people that get ventilated end up not making it off the ventilator and dying. So if that's the case, and that's much higher than what we expect with other types of acute viral pneumonias, if that's the case, then of course you want to do everything to not get them on the ventilator, to try every other strategy to make sure that they improve. And there are some ventilation strategies that are slightly different as well. But that's the goal, is to try to avoid the ventilator if you can. Questions about COVID-19 mutating and 3 strains. So great question. There's a great website called nextstrain.org, but go to the website, check it out. And essentially what they do is they show all the different strains of COVID-19. And basically the word strain is, I think, a bit misleading. The virus mutates, like all viruses mutate, it's normal. And so what we're seeing with COVID-19 is that there are mutations happening, and they are actually not happening as much on the spike protein, which is the key protein that our antibodies are kind of reacting to. And so that's good news. That means that if you have an immune response to that spike protein, it's not changing a lot, so that your immune response will probably stay steady over time. But it does, of course, mutate like every virus does. And they can kind of categorize the virus, and on that website they do by colors. You can literally see how many different colors of virus there are in the family tree, and kind of how they all kind of came back to a root virus. So you can see this happening in real time. It's a very clear example of what I would say is that there are not 3 strains. Depends on how you classify it. You could say there are 10 strains or 20 strains, or you could say it's one family. And I prefer to just think of it as one family, because basically what matters is the part that our immune system is recognizing, and that part is stable. So if that part's stable, I consider that as one group of viruses or one family, rather than 3 strains or however many strains you decide to kind of call it. How long does one remain infectious if they have had or had the virus? So I'll say that generally speaking, if you have the virus, you're considered infectious before you show symptoms. That's now more and more true. In fact, you can spread the virus through what are called bioaerosols, fancy word for what I would call tiny particles of spit. And so these little tiny, tiny, tiny particles are liquid and have the virus in them. As they get out of your mouth, they kind of evaporate a bit. They become smaller and smaller, and therefore they can float longer and longer in the air. And we know that the virus can linger in the air for a few hours. These bioaerosols that I'm talking about, if that's the case, then what it means is that you can essentially spread it when you're pre-symptomatic or asymptomatic. And we think that's where a lot of the spread is happening. Now, once you have symptoms, typically you have, I would say a lot of it is based on expert opinion, but you kind of are assumed to be contagious during those symptomatic days. Now, let's say you stop having symptoms on a given day. How many more days are you symptomatic for? It's really unknown, to be perfectly frank. What I've seen in terms of guidelines are 3 days. This is just, again, it's a best guess. The guess is that you're going to be symptomatic for a few more days, and it's sort of a buffer, because we know that the amount of virus that you put out there matters. And with each day that you're not symptomatic, the amount of virus is less and less and less. Now, some people, like myself, have a cough that lingers forever, and that's because there's a little reactive airways disease. That's not necessarily infectious, but it is irritating. And so there's also symptoms that can go on for a long time, but it doesn't actually mean there's virus necessarily in that cough or sneeze if it's coming from a different cause. All right, let's see. Other questions. Are cloth masks useful? So This is a great question. There's more and more data that masks are probably quite useful. In fact, in many places will probably be mandated. So if you're going out in public and you're using a mask, you're obviously not allowing the bioaerosols to get out there if you are infectious, and that's called source control, you being the source of the infection. So if you have something on your face, it can't get out there as quickly, and it's certainly not moving horizontally. It might be going up or down or sideways, but it's not going as much straight at someone. So that's another thing that changes the dynamics of how it lingers in the air. In fact, if you can get it to go down, that's much better than having it kind of linger in the air. That's the first thing. Two is that on the receiving side, if you're wearing a mask, and they're not called masks because people don't want to get them confused with surgical masks or N95 masks. So I'll use the appropriate language, which is face covering. If you have a face covering, which I think until now everyone just calls that mask, but anyway, face covering is essentially effective depending on what it's made out of. In fact, I did a daily video on how to make a face covering, essentially using polyester and then underneath it, kitchen towels. And with that combination, there's a study that looked not at COVID-19 or SARS-CoV-2, but it looked at avian influenza virus. And with avian influenza virus, it actually blocked out 95% of the virus from getting inside. And they sort of simulated what breathing would look like. And most of the virus got caught up in that mask. And the beauty of that mask, because polyester with kitchen towels, you just take the kitchen towels out, throw them out at the end of the day, and put new ones in. So that's a beautiful example of something you could, presumably make at home and would be pretty effective at blocking out the virus on the receiving end. So both on the source control side and on the receiving side, there is, I think, a strong argument to be made for using these face coverings or masks. Okay. Can I compare swine flu with this pandemic in terms of infectivity, death, etc.? So I don't have the numbers in front of me, but what I will say is that in general, this disease is much more infective than any of the recent flus that we've seen. So that's just based on the R naught of how many people kind of get it. If one person gets it, how many more people get it? And it's roughly twice as infective as some of the recent flus that we've looked at. But again, I don't have the 2009 swine flu data to give a specific comparison to that one. But in general, it's much more infective. Okay. What's the role of a rheumatologist in COVID-19? Great question. I would say that the biggest thing that rheumatology has been dealing with is the run on hydroxychloroquine. So people heard that it's effective. You heard my take on it earlier, that actually the data is very wish-washy and maybe not even that effective, and maybe the toxicity actually outweighs the benefit. But having said that, rheumatologists are dealing with it from the standpoint of that is a medication that is a key part of how their patients get by. And so they're trying to figure out ways to procure enough in this case, hydroxychloroquine for their patients to not have to feel like there's a lack or that they're not going to get their medication. That actually, in that context, work very well. Is there a reason why some ICU patients are prone? So, good question. I'm actually going to do a whole video on this, which is around positioning. But the idea is that what happens when you're prone, and this, of course, is your body position kind of being on your stomach versus supine on your back. In that position, intubation and other things are tricky, but it can be done. And the idea is that you're recruiting different parts of your lungs. And this also gets to another thing that I've seen recently, which is around atelectasis, or kind of when your lungs starts to compress in certain areas, and people talk about deep breathing exercises and holding your breath for a little bit. And those things really matter and help tremendously. So it is important to do those things. It is helpful, and more societies are coming out in favor of prone positioning during ventilation. And it's a tricky thing, not only just like logistically doing it, but it's a tricky thing to even have data around, because we are in real time trying to figure out what works and what doesn't. And there's so many variables that it's hard to know if this is one that also helps. I also talked about L and H patients earlier. I think it'll be important to understand which patients is this more useful for. Is it more for the folks that are having ventilation problems, or more for the folks that are having perfusion problems? So this is still in the works, but I'll be doing a daily video on prone positioning with some data that will help support that and fill out that answer in a little bit more detail. When do I think the pandemic will end? I think that I mentioned the US, I think will end, at least in terms of de-isolation. In some ways, we're going to still isolate, I think, in other ways, but in some ways, we're going to de-isolate a little bit of the country, hopefully no earlier than May 30th, but I suspect that maybe some parts will de-isolate earlier than that. Having said that, the pandemic is a global phenomenon, and there are many countries in the world that will have a hard time getting access and getting the money and the financing for vaccine. What that means is that all of the richer countries need to step in and figure out how to get vaccine logistics out there for the world, because otherwise this will keep seeding our countries. This is not a situation where we can kind of ignore the plight of the poor countries, which we often do, which is terrible. In this case, there's a direct investment that needs to be made so that the pandemic ends everywhere. And most estimates around when vaccine will be available for the masses, and I don't mean just healthcare workers, but everybody, are really looking at spring of 2021, so about a year away. So at that point, we should have everything kind of in place to get the vaccine out as broadly as possible. Is it safe to go out to the store to buy groceries? Safe is a word that now should be thought of as a relative word. So it is relatively safe for a person that is in a low-risk group, so let's say younger, no comorbid illnesses, no asthma, no diabetes, that kind of a person, to go to a grocery store wearing a mask, buying what they need quickly, not being in a crowded store, but in a very sparsely, carefully choreographed situation where just a few people are allowed to enter in, few people are allowed to enter out. That person comes home, cleans their groceries carefully with water, if they're like fresh vegetables and fruits, gets rid of all the outside packaging and wipes it down and discards all that stuff. That is safe. I think doing grocery store drops where you give food to folks that are high risk is also not just safe, but necessary. So I think these things can and should be done. Each of those visits is a potential risk. So the biggest thing is don't go to the grocery store multiple times a week, right? So go once, ideally every couple of weeks. Get all the things you need for the next 2 weeks, put it all in your fridge, cook for a couple of weeks, call it a day. So that's what I would do, and that's what I would suggest others do as well. How sensitive and specific are RT PCR? This is a big challenge, a big challenge. RT PCR sensitivity is where you're trying to catch all the cases, right? And right now, it depends on the site. So if you're talking about a nasopharyngeal swab versus a sputum versus, let's say, bronchoalveolar lavage, where you literally wash out the lungs. Now you're thinking, who washes out their lungs? Nobody. It only happens in the ICU setting where you're very sick and you might be sending off other labs. Once in a while, you might do it that way. The BAL washing, the lung washing, is great. It's very sensitive. It's like 93%. But nobody really effectively gets that done. Almost everyone's getting an NP swab or sometimes even a mid-turbinate swab, which is just in the upper part of the nose. Those swabs are closer to 70%. And it also is going to vary by who does it. Like, am I doing it where I'm like going in there and kind of rolling it around? Or is it somebody that's just doing a home testing kit, has never done it before, feels a little uncomfortable and just goes in and out, and then that's it? So these are all variables that we have to consider with sensitivity. It's 70% at best. It might be even lower. Having said that, combination testing might be the key here. So what if you actually looked at someone that has RT PCR positive plus has serology positive? And then you say, well, together our sensitivity gets boosted. And in fact, in one of the daily videos that I did this week, I looked at data that shows that the boosting effect is pretty phenomenal. If you have a positive IgM or a positive IgG or an RT PCR positive, any of those, then you have an active case or someone with disease or had disease. So those are better ways to test for it. We can also talk about early versus late. Maybe early in the disease, the testing is going to have a lower sensitivity, whereas late in the disease, where your viral titer is quite high and the virus is kind of shedding out of everywhere, you're going to catch it more easily. So all these things affect testing, and increasingly, I think we're going to look at combination testing to figure out who has it and who doesn't. All right, let's see. I'm a nurse working in Ireland. Should all nurses be wearing masks? Management aren't facilitating us to wear masks. First of all, that sucks. I'm really sorry for you and your situation, because you should be given a mask. You should be protected. So if you're in a situation where you are not feeling safe, you got to speak up. Now's the time to make sure that you and your own health are coming first. It also affects the fact that you might take it home and give it to loved ones. So it's not just yourself, but it's your entire family or household contacts. Secondly, there is now data and protocols. Actually, I just saw a study around how the NIH, I believe, just confirmed that you can recycle N95 masks. You can sterilize them and reuse them safely. They don't degrade or fall apart. And that means that you can now reuse a mask. So for example, there was one study out of Stanford that showed using heat was most effective. The NIH study actually, I think, showed aerosolized hydrogen peroxide was very effective. So it depends on the modality you want to do it. Either bake the mask in an oven for 30 minutes, use hydrogen peroxide. Another way of doing it is UV light. There are different ways of doing it. All of these ways are effective at sterilizing and also don't degrade your mask. So if you can get your hands on one mask, I would start talking to your hospital about getting these recycling situations going so that those masks can be reused over and over, not just for you, but your entire cohort of healthcare providers. All right, let's see. Hello, doctor. What are the health implications of COVID-19 on asymptomatic patients? Generally speaking, asymptomatic patients, if you have the disease, you test positive, so you know you have it, but you have no symptoms whatsoever, the long-term health consequences of that for yourself are almost clearly going to be none. So typically, you're going to go through that course. You may not even know you had it, and then you're going to walk away really unchanged. So I'd say your health risk is very low. But of course, the chance of you spreading it to other people is very high. And in fact, there's some data to suggest that it might even spread more in asymptomatic people than in symptomatic people in certain scenarios. Maybe you have more of the virus in your upper airways, and therefore you're kind of launching it out, even when you're talking and breathing, when you're not necessarily having symptoms, but still you can put it out there. Whereas other folks with disease deeper in the lungs, maybe they don't have as much virus in the upper airways. So this is all being researched, but the fact is you can spread it, and that's where the real risk is, not your health, but other folks' health. Okay. That is my time. Let me actually just jump down and talk about a couple of more things. I did cite these daily reports, so please check out the daily reports. The whole point of those is to dive deep. They're real short, like 5-6 minutes, but we talk about the data, and so you can just draw your own conclusions rather than kind of taking my take on it. And go look up the articles yourself and read them and share them with your healthcare workers, your friends, colleagues, anyone that wants to stay up to date. We do have a course that gives out CME credits, so go do the course and get your CME units for it. Might as well, because you're learning about it anyway. We have a pledge I mentioned at the top of this round, flattening the curve and raising the line. Take the pledge, get 3 weeks. There's no downside to that, really. And then, of course, we're trying to not just make it all about COVID-19, but also about you and your mental and physical well-being. So we have, for example, yoga. We have meditation sessions. So we have other things you can join us for. And yoga is happening this Saturday, so please join us for that. We, of course, are going to continue this weekly, so you can throw in your questions. And if you feel like week after week you're not getting it answered, just email us, I suppose, or whatever you can, or post it on social media, and we'll see it and we'll try to answer it. And then finally, we have our resource page, of course. So osmosis.org/COVID-19. Go there. We actually just did our April drop. And so that has a bunch of new stuff in it about the things we're just talking about right now. And that video is, again, very shareable and kind of gets into the details that sometimes I'm unable to get to just through this. And finally, we're here. We have your back, and we know how hard this is. This isn't going to be forever. And so, find the silver linings where you can find them, and be well. Take care of yourselves. We really do care about you, and for the healthcare providers out there, we deeply, deeply appreciate you and love you and want you to know that we're here for you. So please let us know if there are things we can do to help out. Take care.